So the neural anatomy, though may not be of particular significance with regards to gastric adenocarcinoma, but in terms of other benign surgeries, we do need to have basic knowledge of the neural anatomy. Of particular interest are the both vagus nerves, which are the parasympathetic presynaptic nerves. The left vagus is anteriorly located at the hiatus, and the right vagus is posterior in location. The left vagus gives off hepatic branches, which are seen in the gastrohepatic ligament along with the accessory left hepatic artery. And there are the nerves of Latajet that are from the left vagus. The posterior vagus mainly gives off branches to the celiac axis. So the microanatomy, just a brief touch on it. As we all know, like all other hollow organs, stomach has 4 layers: mucosa, submucosa, the muscularis propria, and the serosa. Mucosa in turn is again made up of 3 layers: the epigastrium, lamina propria, and the epithelium. And any tumor that invades through the lamina propria now becomes T1A instead of the tumor in situ. The submucosa is the loose areolar tissue and has no glands, like in duodenum, which has the Brana's glands. And the muscularis propria, the stomach has 3 layers instead of 2. The external longitudinal, middle circular, and the innermost are the oblique fibers, which are arranged in an inverted U-shaped manner. So now that we've had a touch upon the gastric anatomy, what it means as a surgeon for us to learn about our anatomy. So for us, the applied anatomy is the most important aspect in any clinical scenario. As in any organ, when you are dissecting, the key steps are: first step is dissection, mobilization, and then reconstruction. So the first 2 steps, you need to have a good anatomy knowledge. So we've divided the applied anatomy into 4 different zones: the GE junction and the gastroduodenal junction, lesser curve, and the greater curve for the applied parts. So the GE junction, we know it lies at the hiatus. The main structures that we need to pay attention to when we are dissecting at the hiatus is the gastrohepatic ligament. As we all know, it has the accessory left hepatic artery. And in some patients, 3% of patients can have a replaced left hepatic artery that arises from the left gastric artery. And also the left branch of the hepatic branches of the left vagal nerve. And the surgical anatomy part, when especially in the minimally invasive, the esophageal fat part, we all know is a good landmark for dissection, wherein you'll find the left vagus. And also posteriorly, you'll have the both diaphragmatic crura and as well as the posterior vagus. And this is also a site for posterior collaterals. So gastroduodenal junction, it mainly has important vascular structures around, and there are dense vascular synapses around. The special interest is of the right gastroepiploic vessels. As we all know, in cases where we need to do a stomach pull through, this is the vessel that we need to preserve. And the gastroduodenal artery that lies posteriorly, it gives out the right gastroepiploic vessels, and that GDA is, as we all know, is the most common artery that bleeds in a peptic ulcer disease, though not significant to the malignancy aspect, but still relevant. And the gastrocolic trunk of Henle, as we all discussed, just lies in the inferior aspect of the pylorus. It can cause troublesome bleeding, especially in bulky tumors which are at the distal stomach, and also the right gastric vessels. And this is also the site where you dissect out the station 5 and station 6 nodes when you are doing a D2 gastrectomy. Now coming to the lesser curvature, it has the gastrohepatic ligament, the right and left gastric vessels. So replace left hepatic artery, as we already discussed. And this is a site where we get access to the celiac artery and the aorta, though in other benign cases we do dissect, like the celiac artery access, we follow the left gastric artery, reach the celiac, remove the celiac nodes. And in cases where you have to go up to the aorta, this is the site we get access to it. And the other important aspect is the omental bursectomy that we do in advanced GA cancers, especially stomach cancer. The omental bursa reaches up to the gastrohepatic ligament. And this is where we'll find the nodal stations 1, 3, 7, 8, 9, and also the 16. The greater curvature, it mainly has the gastrosplenic and gastrophrenic ligaments, deposition of which will help us in mobilization of the stomach. And there's also the site where we start dissecting the omental bursa in doing the bursectomy from the anterior surface of pancreas all the way up to the lesser omentum. The short gastric vessels and the left gastroepiploic vessels are seen here. And fundus, as we already discussed, are the site for portosystemic collaterals. And once you mobilize the greater omentum, this is where you start dissecting your station 2, station 4 nodes, as well as the splenic hilum nodes and also the proximal splenic nodes. So sound anatomy, it aids in safer, faster, and oncologically efficient surgery, and common variations that are commonly seen should be kept in mind during surgery. And like Sir William also said, if pathology is the king, then anatomy is the queen. Thank you.